So tonight, I try and, my thought is these talks are for you guys. They're not for me, right? So hopefully it's a topic that's of some interest and some utility. And I was trying to find a fun title for my talk. I couldn't come up with anything great, but I was coming up with these from 0 degrees to 100 degrees. But essentially I was trying to think of something to do with environmental illness and environmental problems, right? Everything from hypothermia to hyperthermia, heat exhaustion, and heat stroke. And why did I pick this topic? I picked this topic because who does this stuff happen to? It doesn't just happen to our patients.
It happens to us.
It happens to us, right? And we've had a few instances of people that have been borderline hypothermic. We'll talk a little bit more about that. We've definitely had people that have suffered from symptoms of heat exhaustion, both during real searches and during training. So we have to be able to, in the field, know what we can do to prevent these things. And then, as important, we need to be able to recognize the signs and the symptoms in the field. We'll talk a little bit more about it, and I'll give you an example. But as you've heard from me before on other occasions, I'm not the best necessarily at recognizing these symptoms in me. Pretty good at recognizing them in somebody else, but when it happens to me, I'm just a little, maybe I'm just a little dehydrated, or I didn't sleep well last night, so I'll be fine. Let's go, right? And then we also need to know, once we recognize these things in the field, how to treat them in the field, with the goal of intervening early enough to keep our team members and ourselves in the field and useful on the search. In other words, we don't want to become the incident within an incident. But then we also have to be able to recognize when, this is really serious, and although we need to start treatment in the field, we also need to evacuate somebody immediately. And again, we'll talk a little bit more about that. And then, of course, this stuff applies to our patients too, right? So we always tend to think of it as, the patient that we're going to be treating, but it's probably us just as much. So I think there's two main types of exposure. The one that we always think of is, I didn't dress warm enough and I got cold, I overheated and I got hot. But we also, and hopefully we'll think about this in a little foreshadowing maybe for Saturday, when we have a trauma patient in front of us and it's cold out and they've been laying in the snow with a fractured leg for half an hour before we get there, and we jump in and start treating their fracture, and then the patient starts deteriorating in front of us. They might be deteriorating not necessarily from blood loss and shock, but actually hypothermia, because we're not recognizing that and treating that in the field. So I thought before we delve into the cold injuries and the heat injuries, I just wanted to review real quick heat exchange mechanisms, how we as humans either gain or lose heat, because I think, at least the way my mind works, if I understand the why and the how, it helps me remember what I'm doing in the field, and it's easier to think through things, because memorizing a bunch of things, here's the 5 things we should do for hypothermia, that's great, but if I understand why am I doing this? Now that all makes sense, right? So these heat exchange mechanisms, and these can either work for us or against us. And I think that's one of the really cool things, of presenting both cold-related injuries and heat-related injuries, because you're going to see how some of these things can hurt us, some of these things we can actually use as treatment. So the first one is conduction, direct contact with the ground, right? That's probably the most obvious. If I lie on a cold ground that's frozen, I'm going to chill down pretty quick. If I lie down outside on the asphalt when it's 90 degrees, I'm going to warm up pretty quick. Then there's evaporation. That's when I sweat and it takes heat. Remember high school physics kind of stuff, right? So I've got water on my skin. That's going to get converted to a gas. And so it takes heat to do that. So when I evaporate that, it's going to cool my skin. Then there's thermal radiation. This is the heat that I give out, or the heat that my body takes in from going and standing next to the fire. And then the final one is convection, and convection is fluid or a gas moving over the skin, right? So if I have a cool breeze coming across my skin that's constantly cool, always cold, even though my skin is working to heat up the air immediately adjacent to me. It's blowing away, and I'm constantly exposed to colder air, which continues to cool me. So again, we'll see how each of these can be helpful and harmful. And then right before we dive into hypothermia, one little special topic when it comes to conduction. What about water? How much more effective is water at conducting heat than air? Anybody want to make a guess? How many times more effective? So you jump in cold water, you get out and you're immersed in cold water that's...
Is it more than 20?
It is more than 20, yeah. 24 times more effective, right? So cold water, a real bad actor when it comes to hypothermia, but in heat stroke, it can save your life. So let's talk about hypothermia a little bit. So hypothermia, pretty much, I'm getting cold, and for me to get cold and get hypothermia, my body's regulatory system can't keep up with whatever the environmental challenges are, right? And I start to lose ground, and once I start to lose ground, it's really tough for me to catch up. What are some things that might predispose me or anyone else to hypothermia? Anybody know?
Dehydrated.
Dehydration, right. And do you know, not to pick on you, but what's the why behind dehydration? Why? So Terry's dehydrated, Karen's not, and Terry's more prone to getting hypothermia. Why is that?
Got to keep your motor going.
Yeah, decreased blood volume, right? So there's less fuel in the tank, so to speak, right? And so when it comes to things like blood volume, the body prioritizes getting blood where? The brain, the heart, the vital organs, right? So there's less blood to go to the periphery, the arms, the legs, the muscles, the gut even. And so if I'm shunting blood away from my extremities to prioritize here, this is going to be more prone to cooling at a faster rate, right? So dehydration's a bad actor. Fatigue is another one. Why fatigue?
Not sufficient to moving your blood around again.
Yeah, decreased energy stores, right? It's going to take extra energy to, I've got to get my heart rate up to start pumping that blood to other areas. If I'm fatigued, it's just harder to get that done, right? If my muscles are fatigued, it's harder for my muscles to start being active, right? My muscles are more prone to cramping, going into spasm. And then another big one for hypothermia is actually, and we see this in a lot of winter sports, overexertion. Overexertion where you sweat and you soak your base layer. And why is that a bad thing? It comes right back to that conduction, right? All of a sudden I've got a soaked base layer and I'm conducting 24 times more than if I had a dry layer. So I'm going to cool off really, really fast, especially if I take my jacket off to cool down because I'm so hot that I'm sweating underneath. Now I take my outer layer out, and what happens? A little breeze comes along, evaporative cooling. I'm going to cool really, really fast. So those are some things that predispose us to hypothermia. So talking about hypothermia, 99.9, there's different ways to classify hypothermia, but essentially it's classified as mild, moderate, or severe. 99.99% of the hypothermia that we are ever going to see is mild hypothermia. Because when you get to moderate hypothermia, you are starting to enter the phase where you're actively dying. And when you get to severe hypothermia, you're pretty much dead. Right? So our goal is to recognize hypothermia in the mild stage and never let it get to the moderate or the severe stage. If we happen to come upon someone in the moderate or severe stage, we'll talk a little bit about how to treat that and how to recognize that. But what are some of the signs and symptoms of mild hypothermia? Shaking, right? So tremors.
The mumbles.
Mumbles?
Mumble, stumble, fumble.
Yeah, all right, so mumbling, stumbling, fumbling, just kind of slow. Everything starts slowing down, right?
How about blue lips?
Blue lips could be, yep. Poor circulation.
When a little kid gets out of the pool.
Yeah, absolutely, right? How about poor judgment?
Yes.
Somebody's just not quite thinking right. Here's a tough one. How about It's 3 o'clock. Gareth, I think I'm just done for the day. I mean, we've been out here searching, like we haven't found anything. It's cold. I'm ready for dinner, and I think I'm just done. I think we should just head back, and maybe you could come pick me up at the trailhead. Does that sound okay to you? Like we just call IC. I'm done. What do you guys think of that?
You're a quitter.
Well, quitter. I'm weak. That's right. What do I need from Gareth? I need a pep talk. Right. But apathy. Apathy is a huge one. And that's one that we often miss. The person that's just sort of like, I wasn't really shivering too much. I wasn't really mumbling. I wasn't really stumbling around. But all of a sudden, before I was gung-ho, let's go do this search. And now I'm just like, I just don't really care anymore. I'm just done. Right? Apathy is a big sign. That should provoke, hey, what's going on? Maybe a few more questions and a little bit of check. So those are the symptoms of mild hypothermia. Technically, these mild, moderate, and severe stages are based on core temperatures, and there's a lot of talks you go to. There's talks about what somebody's body core temperature is, but the reality is in the field, we don't carry rectal probes, and we don't carry esophageal thermometers, and that's really the only way to accurately judge someone's core temperature. So in the field, for practical purposes, we don't really use core temperature. We use clinical signs and symptoms. But what if somebody starts out with mild hypothermia and now they start progressing to the active stage of dying? What starts happening to them? Everything slows down.
Shivering.
They stop shivering.
They stop.
Right, so they might actually look, hey, he's sitting over there and he was shivering before and now he's not shivering anymore. But what else he's doing is he's going into what we call a stupor, the 1,000-yard stare. There, but not really there, not really responsive. Clearly, judgment is impaired, communication is impaired, and everything in my body is slowing down. My blood pressure is dropping, my pulse rate is slowing down, my respiratory rate is slowing down. I'm actively in the process of starting to die, right? And then this is one that I think like really cool things. You hear about this like on Mount Everest, or even Mount Denali in Alaska with high mountaineering kind of stuff, where right before somebody dies, they start undressing. What's with that? You're actively dying, you're hypothermic, you're freezing, but now you're going to take your hat off, you're going to take your down parka off, you're going to take your gloves off, and they're going to find you the next day in your base layer with all your warm clothes next to you. Why does that happen? Anybody know?
Is that hallucinatory?
You would think. There's actually a really cool physiologic answer for that. And the best explanation I've heard for that, right, is essentially when I'm in moderate hypothermia, I'm totally losing my thermoregulatory capability. Right? My nervous system isn't communicating with the rest of my body, and I'm actively in the process of dying. And so what happens somewhere pretty far along that process is normally the brain, the nervous system, should be saying, what should I be doing with my peripheral circulation in my arms and my legs if I'm freezing to death? Should be constricting, right? Let's get the blood out of the arms and let's keep that nice warm blood in the core where it's needed. But all of a sudden, that regulatory response is totally gone, and the blood vessels to the periphery vasodilate, and I get this surge of blood right before I die, minutes to half an hour before I die. And so what does that feel like? You get a surge, it feels warm. All of a sudden, I get this flush of warmth. I feel really warm. And even though my core temperature is going and everything's slowing down, I paradoxically undress and hasten the process. So I think the only consolation there is not that I would suggest anyone try it, but if you're ever to die of hypothermia, it sounds like you'll die feeling warm, not frozen. Kind of interesting, huh? So that's moderate hypothermia. And again, the likelihood of us seeing that is really, really low, because we should never have anyone on our team or any other team that we're searching with get to that stage, we should be adept at picking it up and treating it at the mild stage. But I suppose we could have a victim that was in that mild stage. And that could be really tough to differentiate from other medical illnesses, right? Someone that's just sitting there, not shivering, kind of stuporous, maybe they've got low blood glucose, right? So a lot of this depends on, you sort of have to be a little bit of a detective, right? What are kind of the circumstances? If it's 75 degrees out and the person's sitting there doing that, you're like, well, probably not moderate hypothermia, right? But it could be, I suppose, if they fell in an icy cold river or something, right? So you kind of need to know a little bit more about what's going on. And then,
I have a question.
yeah.
So is that the reason why some of the dementia patients that we find, they're basically undressed? Or is it mostly because they are hypothermic by that time? Or is it because there are some other reasons?
It could be, dementia is a really strange thing. Dementia obviously typically occurs in old people. And we know that as people age, they also lose their thermoregulatory capability, right? So all of us, when we're 10 years older than we are now, our body's not going to be quite as good at adapting to cold and heat. And that's why, right, when you hear every summer in the news, right, there's a heat wave in Chicago. Well, who dies in the heat wave? Mostly old people, right? Or, oh, there's a freezing spell in Alaska. Well, who dies in the freezing spell? Mostly older people. And that's oftentimes why, you see the 89-year-old woman on a day like today in the grocery store with a down parka on, right? She actually might be kind of cold. She might not be demented or crazy, But yeah, that's a tough one. Yeah. And then severe hypothermia. So severe hypothermia is you're essentially dead, right? You're unconscious. You've got, that AVPU scale that we use, and we'll talk about that more in the secondary survey. And the AVPU scale, A is for alert, V, verbal, you respond to verbal stuff, P, you respond to painful stimuli, and then a U, you're unresponsive. People with severe hypothermia are a U. They're unresponsive, right? They're unconscious, they're unresponsive, and many times they're in cardiac arrest. So they're already essentially dead. So how do we treat this stuff? Well, mild hypothermia, step number one always is if they have wet clothing, before you do anything else, get them out of that wet clothing and get them into dry clothing. And why do you think that is?
Conduction.
That conduction, right? So they don't just get hypothermic and then sit there waiting for you to treat them. They get hypothermic and they're getting colder and colder and colder, and we need to intervene and actually reverse that curve. So the first thing we want to do is stop the harm, right? So get them out of the wet clothes, get them into warm clothes. And then the next things are kind of all obvious things, right? We want to get some insulation on them, right? To prevent that radiating heat from going out and radiate it back in. And then, and we know this from doing the hypo wrap, but you always insulate from the ground up. And again, you're just going to leave somebody laying on the ground and throw some blankets on them. Why? Because that cold ground is doing what? Pulling heat out of them through conduction through the ground, right? And there's actually, we talk about using a hypo wrap. There's actually a hypo wrap demonstration and instructions in here. I'm not going to go through it because it's in here, and we'll get a chance to practice that in the field. What about, and then the other thing to do is giving them some carbohydrates. Carbohydrates are a little bit of fuel, just a little bit of something in the stomach, really gets that metabolism running and can make a huge difference. What about warm liquids? Anybody heard of that? Give them a cup of hot chocolate, cup of tea, cup of coffee, yay or nay, or?
Yeah.
It sounds good, doesn't it? Sounds logical, and that's what we've heard for years. It turns out, other than psychological comfort, doesn't really do anything. It's actually the small amount of liquid that you put in their stomach isn't really enough to shift their core temperature one way or the other, but actually a little bit of carbohydrate in the gut is enough to make a huge difference. So far more important to get some carbohydrates in them than warm liquids.
I know Val would take hot Jello in a thermos when she was
Yeah.
doing winter
Yeah,
stages.
and it was really the Jello. It's the carbs in the Jello, and then the psychological support of because who's going to drink ice cold Jello water when they're freezing, right? But if I'm freezing and somebody gives me something warm to drink, that's going to psychologically feel pretty good. It's probably going to taste pretty good. I'm going to be more inclined to
Protein and
consume
carbs,
it.
yeah.
And then obviously we want to hydrate them. Why? Because like we talked about with Terry, dehydration is predisposing to hypothermia, so oral fluids are good. And then as long as we do that, do we have to call for an evacuation on somebody like this? What do you think?
Yes.
Yes.
You gotta monitor.
Not necessarily, right? So I get a little cold in the field, some mumbles, some stumbles, that apathy thing, and Gareth comes over and goes, hey, what's going on? And he goes, hey, it looks like you're shivering there. And Gareth's like, well, look, your base layer is totally soaked through. Do you have any dry clothes? So maybe I put a dry base layer on. He gives me a little carbohydrate, has me sit there and drink a little fluid, put another layer on, and all of a sudden I'm like, I'm feeling much better, Gareth. I think I can do this for another 2 hours, right? Treatment in the field, probably okay. So you don't necessarily need to evacuate somebody. But again, that depends on the circumstance. So if we recognize it early enough, treat it early enough, we can take care of it in the field. What about hot water bottles? We've all heard about this. Good thing, bad thing, indifferent?
Good thing.
Good thing, okay. Where do you put them?
Armpits and groin.
Under the arms,
Right, and why do we put them there?
because that's where your big veins are to warm up.
Yeah, that's the closest where you have veins to the surface of the skin. It's just more effective there. The one thing you got to be careful of with hot water bottles, though, is making sure that we don't cause thermal burns, right? Oh, I just boiled some water on my jet boil and put it in this stainless steel container and stuck it in the armpit, right? And now I got a second-degree burn in the axilla, right? So, and this has happened. Right, so more often than you think. So we just got to be careful about thinking that through and about insulation. How about this one? I'll tell you a little story about this one because this is really interesting to me, and this is something that happened to me. And I think I told you that I wasn't really good at recognizing things when they happen to me. Many of you heard the story. I was backcountry skiing. I fractured my ankle, and I wound up getting hypothermic and shocky, and drove back to the hotel by myself. And knocked on the hotel door and told my wife that I wasn't feeling so well and that I'd injured my ankle. And she took one look at me and was like, "Oh my God, you look like hell, right? You're pale, you're shaky." I was, sort of tremulous, right? And I was really cold at that point. And so my wife said, "All right, let's get you into the shower and warm you up." And so I quickly got out of my clothes and hopped on one foot into the shower and turned on a really hot shower. And about a minute later, I almost passed out in the shower. Why is that? Yeah. So my skin warmed up really fast while my core temperature was pretty low. And as soon as my skin warmed up, what did my brain think? Oh, we're nice and warm. In fact, we're getting a little too warm. We need to get some blood flow into those extremities to cool you off. And so the blood went from my core to my extremities, and my blood pressure went, and I almost passed out in the shower. Fortunately, I didn't. But I wasn't savvy enough at the time to sort of recognize what was happening to me other than I felt really woozy, which I attributed to any number of other factors. But when I sat down and thought about it after, I was like, yeah, that hot shower probably wasn't such a good idea. So when it comes to like a hot shower, we want to think of warming someone relatively slowly, right? So maybe check on their hydration status. Have they peed? If they peed, what color was their pee, right? If it's pretty clear, okay, they're hydrated. We've already warmed them a little bit in the field. The hot shower is a good idea, but a little more delayed and maybe a little more gradual, and maybe having somebody else in the shower kind of keeping an eye on things to make sure they don't go. So an easy trap to fall into. All right, so that's, what about moderate hypothermia, right? This is the person that's stuporous, they're minimally responsive, they're in the act of dying, these are the people that we have to think evacuation immediately. We're not going to fix this in the field. We can try. There's some things we can do, and they're all the things that we would do for mild hypothermia, except we're not going to give them anything to drink, and we're not going to give them anything to eat. And why might that be?
Aspirate it.
They're already stuporous, right? They're probably not going to control their airway. They're high likelihood they might vomit, aspirate. We just make things worse. So we want to kind of protect their airway. And then the other thing that's kind of unique to hypothermia is that when the body's core temperature gets really low, the heart gets really irritable. And so these folks are very, very high risk of going into a cardiac arrhythmia. So if we handle them roughly, we log roll them and we drag them onto a litter, and they're very likely to go into a cardiac arrhythmia. And that in and of itself could be fatal. So we always talk about being very gentle and keeping them in this horizontal position. And then what about this severe hypothermia? We find somebody in the field, they're unresponsive, they don't have a pulse, they're clearly hypothermic. They died essentially of hypothermia, but it was pretty recent. What do you think about, CPR in the field? Now, just to back up for a minute, when we talk about wilderness first aid and CPR, various guidelines, various thoughts on this, but generally I think of wilderness first aid as you're more than an hour from the trailhead, or you're more than an hour from definitive care. So you're in the wilderness. You're more than an hour from definitive care. Somebody has a cardiac arrest from trauma, from myocardial infarction, heart attack, whatever. Normally the thought is we don't start CPR that far away from definitive care because the chances of survival are about as close to zero as you could possibly be. But now we found this hypothermic patient, and we got to the scene just as this person, their buddy's there, and gosh, he just stopped breathing, and I can't find a pulse. CPR, no CPR. We're in the wilderness. We're more than an hour away. What do we do? What do we think? Yeah. Right. There's a saying in medicine. You're not right. Adam's got it right. You're not dead till you're warm and dead. So in this situation, we would actually start CPR unless there were obvious signs of, trauma, or, the person's skull split open, or, something like that. They're clearly dead from some other reason. Or if their chest is so frozen solid that we can't do chest compressions, right? Then it's too late. So I got a bonus question here. So I have one of these buffs that I got at this Safety at Sea course that I wound up having to take from U.S. Sailing. So for the buff, what's the one other situation in the wilderness where we would initiate CPR?
Drowning.
Drowning,
Of
yeah.
lightning.
You got them both. Yanni gets the buff. Yeah, normally we think, what I was thinking was lightning, but drowning is a good one. Drowning, primarily a respiratory problem, right? So we think mostly in drowning, if we get a drowning victim out fast enough, it's mostly all about the respirations. And usually if you get the respirations taken care of fast enough, the heart's still going, and we don't even have to do, in many cases, CPR. But yes, that's one where we would consider doing that. And then cold water drowning, kind of the same principles as hypothermia.
Related to the mammalian effect, where the body constricts all blood flow to the major organs, the brain, the heart, and then it kind of keeps the body like in a hibernation.
Yeah, that's kind of the thought. The thought is it just slows everything down. So if you think about it, it slows down the dying process too. Cells keep going just a little bit longer, But a good thought. And then panel 13 on your Wilderness First Aid Guide has how to do a hypo wrap, what the different layers are, all that kind of stuff. There's also a panel there on hypothermia that has some of the signs and symptoms. So if it's one of those things where you're in the field and you're like, can't quite remember those things, especially in a stressful situation, look it up. Questions on any of that stuff? All right, I'm going to talk quickly about frostbite. and then we'll move on to some of the heat-related injuries. So what exactly is frostbite? Anybody know? Like, what's the definition of frostbite? I mean, we all have heard this stuff, right? And I'll be honest, until about 2 years ago, I was like, no, I didn't know the definition either. Just you got cold and bad stuff happened, right? You hear about mountaineers losing their fingers and their toes. So what happens in frostbite is actually water that's in our tissue freezes and turns into ice crystals. And those ice crystals then kill the tissue. So tissue dies. And that's essentially what happens in frostbite. Frost nip, on the other hand, I think most of us have had at some point. Frost nip is probably better called pre-frostbite. And that's superficial, temporary condition that we can quickly reverse. But that's essentially, right, who's been out in the freezing cold and all of a sudden your ear is like numb and then it's just burning, or your fingertips are burning and tingling and it's really painful because it's so cold. Who's had that happen? Yeah, so that's frost nip or pre-frostbite. What happens if we tough it out? Anybody ever done that? Just like didn't, put mittens on instead of gloves, or take your gloves off and stick your armpits, your hands in your armpit, or, quit what you're doing and get warm. Anyone ever just been like, I'm just going to keep going? What would happen if you kept going?
Frostbite.
Frostbite would happen, but this is a really interesting thing. The pain would go away. All of a sudden you'd be like, my fingers don't hurt anymore. That's not so bad. And for at least a little while, I could still use my fingers. So this is what happens oftentimes to mountaineers, right? Because they're taking their gloves off to tie knots in the freezing cold and rig anchors, and it's much easier to do that stuff with bare hands, right? My fingers are so numb that they're killing me, but I just got to get one more knot, and then maybe not so bad. Well, hey, as long as I'm here, I'll do another anchor. And then frostbite happens. So the key thing is recognizing when we're getting frost nip and intervening right away. When you get symptoms of frost nip, that should be a stop what you're doing and fix the problem before it gets worse, right? And passive rewarming works very, very well. Frostbite, on the other hand, your fingers go from white to like a bright red, and then 24 to 48 hours later, you start getting these nasty looking blisters, and then the blisters get filled with blood, and then about 2 or 3 days later, the skin turns black or blue, it's gangrene, and then usually you wind up losing your digits. Whether or not you lose your digits is based on how deep and how much tissue is involved, right? How many ice crystals are in the tissue. And these days, if you get somebody to the emergency room fast enough, there's some medications that we can use to inject that they're like clot busters that can actually increase the perfusion in the tissues and save some tissue. So what are some of the things that predispose us to frostbite? Many of the same things that predispose us to hypothermia, right? Dehydration, wet mittens, wet gloves, wet socks, very constrictive clothing, right? And we see this in a lot of winter gear. Crampons are a big problem for climbers because they've got, especially if you have leather boots or something like that instead of plastic boots, and then you crank down because you want your crampons tight. You don't want them slipping around on ice, but then all of a sudden it starts constricting the blood flow a little bit to the foot, and you're predisposed. And then one of the things that they talk about, which sort of makes sense, but nobody ever does, right, is should we be performing buddy cold checks? So we as a team are going out into a really cold environment. We're all prepared. We've got gloves. We've got extra socks. We're dressed appropriately. The weather's expected to get colder during the day. Perhaps every half hour we should check in with a buddy and see how you're doing. Phil, how you doing? Are you warm? You feeling cold?
About an 8.
Any numbness on your fingers, tips, maybe taking a look at Phil and just making sure that any exposed areas on his skin aren't turning ghostly white. Like, Phil, your nose is looking like really white. Yeah, it's kind of been hurting me for a while. Like, maybe we should cover that up or stop and do something. And then field treatment of frostbite. There's not a whole lot to do for frostbite in the field. And in fact, we can cause probably more harm than help. One of the most harmful things you can do if someone's frostbitten is warm them up and then have them freeze again. That's like the absolute worst thing you can do. That almost certainly guarantees deeper tissue damage and probably loss of digits. So what does everyone want to do? Oh, let's get you warmed up, but we got a 2-hour hike to the trailhead and you lost your mittens in the snow and chances are high of refreezing.
I don't know, but dehydration, I get, would it be better to be more dehydrated? You'd have less water in your tissue to freeze?
No. No, I see what you're thinking, but it doesn't work that way.
Oh,
Yeah,
curious.
yeah, it doesn't work that way. Yeah. You'd have to be freeze dried, essentially, at that point, too.
So I have a dumb question.
Yeah, no dumb question.
You can get hypothermia when it's above 32.
Mm-hmm.
Can you get frostbite when it's above 32?
Generally not. No, because you have to have actual freezing. So very, 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 very rare. I suppose if it was, 33 degrees and you were wet and there was a wind whipping across your skin, maybe that would be enough.
It's actually freezing.
But it's actually freezing, yeah. So generally we don't think of frostbite. If we're going out and the temperature's above 32, we're not too worried about frostbite. So we really don't want to attempt field rewarming unless we're absolutely sure that we can warm somebody up and they won't refreeze. And if we are going to warm them up, we do that with warm water. How warm should the water be? We're in the field, right? We don't have a thermometer.
98.6.
Yeah, so you want it 98 to about 102 or 103, hot tub warm. And a good field test is if the rescuer can stick their hand in the hot water or the warm water. If you can tolerate that for 30 seconds or more, it's okay to use for treatment. If you have to pull your hand out before 30 seconds, it's too warm. So that's the field test that we use for practical purposes. And then, something too that we don't think of, because remember, frostbite doesn't hurt once it happens, right? You lose all the feeling in that limb. What about somebody with a frostbitten foot? I stepped in the creek early in the morning. I never stopped to change my socks. And about 11 o'clock, Phil does a buddy cold check on me, and I can't feel my right foot.
You don't know what other injuries yours is.
Yeah, it's actually a really bad thing. So that should actually be life or limb, then to do it to save somebody's life, but that should be something where I should actually be carried out or evacuated out. I shouldn't be walking on a frostbitten foot. Final thing before we move on to the heat stuff, which is trench foot. This is something that we could get exposed to because trench foot is a water immersion into non-freezing, cold or wet condition, which can happen over hours, over days. So it's 48 degrees out in November, and I step in the creek in the morning, and I'm like, I'm good, let's just keep going. And then about 2 o'clock in the afternoon, bad things start happening to my foot. Do we have socks, a spare pair of socks as part of our 24-hour gear?
Yes.
Good. That's probably one of the reasons why, right? So that should be a stop and fix it kind of thing. So essentially what happens is with trench foot, it's kind of like a frost nippy kind of thing. Your skin gets really pale. It gets numb, cramping. It starts swelling. You're getting bad symptoms in your foot. And then you look, and has anyone ever had that? Where you're looking, your foot's kind of all clammy and pale and swollen. What's the mechanism? It's a cold-related injury. Yeah, so it's mostly the thought is it's the conduction of the wet around the skin that is just pulling heat constantly over a couple of hours, and then you start to get this injury to the tissue. So, all right, we're in the home stretch. 5 minutes to go. Let's move on to heat illness. We've actually had this happen to a couple people on our team. There was a search in Reading, I want to say 2 or 3 years ago, and it was in July, and it was, I think, like 102, 103 degrees. So we're searching. There wasn't a lot of shade, and several people on our team and on the other team got mild, I would say mild symptoms of heat exhaustion that will go through. Really through no fault of their own. It was purely because it was so hot out. So what are the risk factors for any kind of heat illness? Well, temperature, high temperatures, kind of statement of the obvious, high humidity. Here's our old friend dehydration again, poor fitness, obesity, exertion. Why would exertion be bad?
Generate energy.
Because you're already generating energy and trying to dissipate heat, and now you've got this environmental heat on top of you when your kind of thermoregulatory capacity is already maxed out. Sunburn is a bad actor because we lose that protective layer on our skin. Fatigue, and then obviously excess clothing, right? Not shedding a layer soon enough, kind of the opposite of hypothermia, right? We just keep warming that core. We're radiating heat out, and our multiple layers are radiating it right back in, cooking the core. And just like we talked about with cold checks, probably with extreme heat, like that search we were on, I wish that I had thought about doing buddy heat checks, but I didn't. And like any search for any training, right, we think, well, what did we do well? What could we have done better? And what are we going to do different next time? And my take home from that was, yeah, we could have done better at doing buddy heat checks on each other. We might have picked up some signs and symptoms a little bit earlier. So real quick, a whirlwind tour through the heat illnesses. Heat edema. This is swelling of the ankles, the calves, the hands, first few days in a hot environment for somebody that's unacclimatized. And I think of this when I lived in Alaska. What does everybody in Alaska do in the winter? Everybody goes to Hawaii, right? Everybody goes to Hawaii, and what happens on day 1 or day 2 of Hawaii? God, my ankles are swollen, my hands are puffy, because, we're unacclimatized, and you're in an environment that's 85 degrees with 90% humidity. It's absolutely harmless. It takes care of itself, but it's just one of those things to recognize. And I think where it's helpful is to recognize it like, oh, this means I'm unacclimatized. I probably shouldn't go out for a 6-mile run the next morning or something like that. Prickly heat or heat rash. These are those small red dots under the socks. Who's had that? You get back from a hike or a backpacking trip and you take your socks off and it's like, the heck is that rash underneath my socks? It doesn't feel like anything. It doesn't itch. It's just all these little red dots. That's from obstruction of the sweat glands. And it's called prickly heat or heat rash. It's self-limited. Goes away in a couple days, no treatment needed. And then there's this thing called heat syncope, passing out because of the heat. This is a tricky one because just because it's hot out and somebody passes out doesn't necessarily mean that they passed out because it was hot out. It's kind of a diagnosis of exclusion, right? We need to do a full primary and secondary survey and look for other reasons and not just jump immediately to like, oh, he passed out because it was hot out, he'll be fine. Right? Heat cramps, everyone's had that, right? What's the treatment for heat cramps? Stretching, fluids, a little bit of electrolytes, a little bit of rest, a little bit of cooling. Finally, we move on to heat exhaustion. Heat exhaustion is a higher up on the degree of, it's kind of like mild hypothermia, whereas heat exhaustion is just a sense of malaise. I don't feel good. Fatigue, kind of some vague dizziness, little headache, a little bit of nausea, maybe some vomiting, but somebody's got a normal mental status, right? Anybody here had heat exhaustion? Absolutely. How does it feel?
Not good.
It feels pretty awful. It's just one of those things, right, that you're just like, I don't feel good, and I don't feel good in a lot of ways. But it's easy to treat. Stop the exercise, get some shade, get some cool fluids, and usually that's we don't necessarily need to evacuate somebody from the field from that. Its close cousin, though, is heat stroke. And heat stroke looks exactly like heat exhaustion with one exception. The patient has mental status changes. No big deal, right? So they've got mental status changes. If you miss it, though, right? So does anyone die of heat exhaustion? No, they just feel like crap, right? If it goes untreated, they could progress to heat stroke. But how many people that get heat stroke die from the heat stroke? So you get heat stroke out at the Cache Creek Conservancy during training. Heat stroke, neurologic changes, change in mental status, along with not feeling so well. and we go, you've got heat stroke, we're calling 911, we're taking all the first aid measures in the field, what's your risk of dying from that? Statistically, it's 5%. It's kind of scary. Just like hypothermia, where everything slows down and the body starts losing its circulatory and thermoregulatory compensatory mechanisms, when you get heat stroke, you can also start to get a lower blood pressure. What if you get heat stroke and your blood pressure drops? What's your chance of dying then? 1 in 3. That's terrifying. And how easy is it in the field to say, well, there's some mental status changes that are very obvious mental status changes, right? But what about those that are like, I don't know, Greg's acting a little funny, maybe he's a little out of it, but I don't know, he kind of seems like himself. It's kind of a judgment call. I don't know. What do you think, Gareth? What should we do in that situation? That situation, we don't screw around, right? Better to err on the side of saying heat stroke, because the consequences of unrecognized and untreated heat stroke are extreme. And I can't tell you how many people die each year of heat stroke. It's a very common thing, right? And we see it here a lot, right? High school athletes, collegiate athletes, people out recreating. Sometimes it's attributed to another cause, right? Because you can't really, there's no, obvious bullet hole, so to speak, in the patient. They're just found dead by the side of the trail, right? And any number of things could have happened. What about this whole thing with sweating, right? We heard about shivering, right? Mild hypothermia, I'm shivering. I get to moderate hypothermia and I stop shivering. What about sweating? I got heat exhaustion. Chances are I'm sweating. Anybody ever heard this thing about you could tell heat stroke because the person stopped sweating?
I think they used to teach that, but I don't think that's accurate.
Correct. Yeah, if I had another bandana, I'd give you my bandana. Would you like a book club book instead? So, yeah, that's actually true, right? That used to be taught in first aid classes. That was part of the curriculum, but it's actually been shown to be not true. So sweating, lack of sweating, we can't tell. The only differentiating thing is the mental status changes. And so how do we treat heat stroke?
Get them out of the
Shade.
Yeah, get them in the shade, right? But we got them, that's a good one, right? Get them in the shade. There's one kind of thing that works more than anything else.
pour water on it.
Get them wet, right? The opposite of hypothermia, right? The hypothermic patient who's wet, what are we trying to do first and foremost? We want to get them out of those wet clothes because their body temperature is dropping. So this person's cooking from the inside out. Let's get them wet. And then if we can immerse them in cold water, that's absolutely the best thing. But if we're hiking up Mount Talak and we're, a mile from the top, where's the nearest water?
Water bottle.
What we have with us, right? We're not going to go down to the lake down at the bottom. And it's going to take us, 2 hours to get there to immerse them in cold water. We're going to strip the person down, right? Because if we wet them on the skin, that's going to get the evaporative cooling going faster. So strip the person down, douse them with water, and fan them. Because when we fan them, we get some of that evaporative cooling too. So you want to get them wet as soon as possible.
So like when they're cold and you're warming them up, and you said you warmed up too fast, are you going to cool them down too fast?
No, you can't. It doesn't work. Yeah, it doesn't work that way. You don't have to worry about that.
Okay.
Yeah, you don't have to worry about that. I guess if you get to the point where they start shivering and mumbling and stumbling, then you could be like, oh, we've pushed this a little too far, and maybe we need to reverse this a little bit. So yeah, there's finding that sweet spot in the middle.
You don't normally have an ice bath with you when you're out on hot days.
No, but if we had ice packs or something, certainly we would use them. Some people carry, cold packs in their first aid kit, right? So would I crack open a cold pack and stick it in the axilla or stick it in the groin? Sure, it's not going to hurt, right? But the best thing to do would be cold water immersion. You had a question?
I heard that if somebody is like heat exhaustion or there's some heat-related thing is going on, that room temperature water is better than really cold water because of what it does. The cold water causes your body to slow circulation or something. Is that?
Yeah, you could, yes, that's a good point. If we put them in ice water in the field, that could be somewhat of a problem.
I mean, drinking, like, really cold water is not as good as just.
Yeah, it wouldn't make enough of a difference. In fact, what they do in the emergency room for a heat stroke patient is they take a body bag, and they use the body bag, and they get a bunch of ice from the cafeteria, and they fill the body bag half full with ice, throw a bunch of water in there, and they put the person in the body bag, of course with their head sticking out, right? But that's the most effective
Terrifying.
effective way of cooling it, right? And then you can think of all these scenarios, right? Like, well, we're hiking in Tahoe and the lake is partially frozen over. Like, if you're hiking in Lake Tahoe and the lake's partially frozen over, you're probably not talking about heat stroke. So I don't think we have to. But yeah, I guess there would be considerations of, do we put somebody in ice water? The answer is probably yes, because any harm that we could do, remember that 5% mortality rate and that 33% mortality rate. And that's one of the biggest problems with heat stroke. It's under-recognized. And then when it is recognized, people sort of treat it lackadaisically. Like, oh, let's just go have you sit in the shade. We'll fan you a little bit, have some cold water to drink. Let's wait about 5 or 10 minutes. We'll see how you're feeling. No one's activating EMS, and this person is in heat stroke. So there's oftentimes this under-recognition, this delay in treatment, and then kind of this laissez-faire attitude about getting them cooled off. And you're much better to call somebody heat stroke when maybe they were just really severe heat exhaustion, and now they're wet and maybe a little pissed at you, but they're alive and talking. So.